I think we're ready. Oh, Linda's not ready, but we're recording, so.
That's been on all day. I don't know what's going on.
Okay, call the Human Services Committee meeting to order. Is there any courtesy of the floor?
There is, ma'am. Please be heard for a moment.
Yes, what's your name?
My name is Lamont McClure. I live at 4110 Sherman Boulevard, Bethlehem Township. We are going to be hearing from Lori Grieco today, the Area Agency on Aging, and I think Mr. Warner asked a question at one of our meetings recently about the rating. You know, what are we, yellow, red, green? You know, we have star ratings that are constantly coming out at Graysdale, and one of the things I've said about these ratings is they're important because they're a quantitative and qualitative metric of what's going on in a particular facility, but they're not everything. You know, for example, at Graysdale, as we always talk about, we take the sickest of the sick and the poorest of the poor. And if someone has to be on Ativan to keep from rolling around on the floor to maintain that person's dignity, I think that's what they ought to do at Graysdale, even if it costs them some points in a star rating. I think that's the appropriate thing to do. And that's the way we're going to manage it. That's the way we're going to put the person, their health, their welfare, and their dignity first, right? And I think you agree with me. And as far as the AAA and the rating, whether they're green, yeah, I'm really happy they're green because, you know, when we got here, they were in the red and they had such a terrible time getting out of it, and they did such a wonderful job, and I'm so proud of them. But if they were yellow, I would be proud of them. I was after them a little bit, wasn't I? Where's Lori? Yeah.
Right
I was after them a little bit to get to green, and I'm so proud of them if, in fact, that's where they got, because I'm not sure that's where they got, but we'll hear from Lori.
Okay.
But they might backslide again to yellow, but it doesn't mean they're not doing everything they can to take care of our seniors every day. And even if for some technical reason they would have dropped to red, they're still out there protecting folks on a daily basis. And if they drop to red for some bookkeeping reason, that doesn't mean people are in danger. My point is we're not chasing stoplights. We're not chasing star ratings. What we're doing is protecting senior citizens, and we're protecting our residents at Graysdale. And we can't use these measurements as the full metric of how we care for people. That's what I wanted to say. Thank you.
Thank you. We were supposed to have a report from the Early Intervention Department today, but my understanding is Justin's under the weather, so we'll try to get her in at another time. And we'll start with report from Area Agency on Aging. Don't trip on your way up there.
I have solid shoes on. You might have to pull the mic down, Lori. There you go. Okay, is that better? Okay. So I will start with protective services. Thank you for that introduction about that. So we are green, and I'm very excited to say that we're green. We're at a 92% green. We were monitored on October 21st. We do have a lot of changes in our protective services unit. So when I took over last year, we had 3 full-time investigators and no dedicated supervisor. I was covering as a supervisor as well as the administrator of the agency. So since then, we have grown. We do have 4 full-time investigators. One of those positions is currently vacant, but we are filling that. 1 dedicated supervisor. We have 3 non-protective services care managers. They are trained in protective services, but they work in other units in the agency. We have I'm certified protective services. Our deputy administrator is now certified protective services. And all of our care management supervisors are protective services trained. We did recently receive extra funding from the Department of Aging for a 5th full-time investigator and a full-time protective services case aide. So we will be filling those positions hopefully early next year. So that's really going to help us to stay afloat. It is incredibly impressive that our staff got to the green, the 92%. They did that really with just the 3 of them, really working very, very hard. I did a comparison and looking at how many reports that we take, how many investigations we do. We're currently averaging about 80 reports per month, which means our investigators are averaging over 18 new cases each month. The state really recommends that there's no more than...
Lori, hold on. Okay, go ahead, sorry.
Sure. The
So
state
you were saying 80 reports and 18 new cases a month is where I...
Right, correct. The state recommends no more than 10 new assignments per investigator per month. So they're really working double time. And when I reviewed our benchmark reports, the reports of need that we've taken since the 4th quarter of state fiscal year 13-14, it's increased 262%. And the investigations completed have increased 539%. So they're, we're just starting to grow now, but they've been keeping up, and they're doing an amazing job in protecting the older adults in our county. We also did participate in an intake pilot training program. We were chosen by PDA to participate in that. So we did that. Our intake unit did that as well. So that's where Protective Services right now. Our assessment unit, they're fully staffed. They continue to be 100% compliant with their assessment timeframes. They assess individuals to find out if they are nursing facility clinically eligible, to see if they'll be eligible for the waiver program. Our options unit is fully staffed, and that's a big change from when I was last year. Last year we had 2 options care managers full-time and no dedicated supervisor due to staff turnover issues. We now have a full-time supervisor, 5 full-time care managers, and 1 full-time case aide. So they're really doing a wonderful job meeting the needs of the consumers in the community and assessing them and providing for their care needs. They're also trained in person-centered counseling. That is something outside of the in-home services that we provide to help people find the resources to meet their needs in the community, and that requires certification. So they are trained in that, as well as our assessment unit care managers are as well. I forgot to mention that. For our senior centers, our Forks Center is relocating to Park Plaza. We are officially completely out of the Forks Center as of this week. So we're moving into there. Our Bath Center will be closing. Kim Nickel, the center director, and I had presented at a Bath Borough meeting to inquire about alternate locations to have a center. And unfortunately, none of the suggestions to date have worked out. So we may be transferring them to the new Lower Nazareth Center on Buttstown Road that will be opening. I have recently received praise from our advisory council members that there's a lot more activity at our senior centers than there has been in the past. Kim Nickel's working very hard at improving our programming, our state wellness initiatives. Everything's just growing in leaps and bounds. For farmers market distribution this year, we had 47 distribution sites, including mobile farmers markets that were located at the distribution sites. So as soon as the consumers got their vouchers, they could purchase fresh produce with that. We have not yet been audited by the state, so I can't give you a number of how many of those we distributed this year. Our caregiver support program is growing. We have a new full-time supervisor in that program and a full-time care manager. And that supervisor also supervises our Apprise program, which assists with Medicare enrollment. And that's very busy right now because it's open enrollment. The last thing I wanted to report is that last week we were fortunate to have a visit from the Pennsylvania Aging Secretary Robert Torres. He was out to visit us, and he spent some time with us talking about the needs of seniors in the state overall, and especially in Northampton County. That's it.
Do you have questions?
I'm sorry, I'm late. Did you announce that you have the right color now?
We are the right color.
Okay.
We're a solid green.
92%. It's impressive.
It's quite an accomplishment.
Yeah, the staff work very, very hard. We're very proud.
Any questions? I think you've done a phenomenal job considering how long have you been in this position now? When did you take over officially?
In January
of
of
this year?
2018.
Less than 2 years.
John Mallon, big shoes to fill.
Yeah,
Apparently now you have the big shoes.
I do.
Good for you. Do you feel like there's anything you need at this point? You said that they've approved you for a fifth investigator and case aide. Is that 100%, 90% funded? What?
100% funded, and that will stay with us. That's not just for now. That will stay with us.
And do you get most of your calls directly, or do you get them through Iris, or do they come to you all different? How do you get?
Through Iris.
informed?
Iris takes our calls. I mean, occasionally people will call us directly. We can take the referrals and talk to them, but typically that's where the calls are sent, especially for the reports you need, because that's a whole tool that needs to be filled out, and they have that downstairs.
No other question?
Thank you very much.
Thank you. Director?
Thank you. I wasn't paying attention to the order of the agenda. The big thing I wanted to chat about today is the integrated data system that we are hoping to build for human services. I'm not sure if you all heard about that in the budget yet. Is that all? Just kidding. I actually was not, I didn't have the exact number. Okay. So I wanted to talk to you about why the request is being made and how we think it will help us. You all have heard me talk about the 8+ different systems that we have in human services already. So when Iris gets those phone calls, really before they do anything, they're checking all those different systems to see if the individual has any involvement in any of our human services. So it certainly is not efficient. Thankfully, they at least can access the information, just not always quickly. So an integrated data system would certainly allow us to increase that efficiency and the speed with which we retrieve that information. Just want to make another note I don't forget. We would be able to reduce the redundancy of multiple records being held within different systems as they currently are now, and avoid duplication of services for our folks. So some general examples, when we have a family who comes in to children and youth, for example, generally speaking, they either have drug and alcohol issues or mental health issues or both, and oftentimes are involved with one of those two systems. And oddly, we don't always know that right away. And so we certainly, have families sign releases of information and consult with the other divisions, and, those folks have a whole process for that. But having an integrated data system would allow us to more easily know what services all these folks are already getting. One of the hopes would be when we have families, who, for example, have drug and alcohol issues, and they go through an intake with one of our case managers, they tell their whole story. Children and youth knocks on their door, they tell their whole story. Being able to have an integrated data system would improve our ability to work together to have families tell their story one time and not continue to re-traumatize folks. So that would be a huge benefit. It would also help us be able to determine where to best allocate our resources. We all know as much as we get from the state and feds, it's still limited, and there's never enough money to do everything. So the integrated data system, part of which is certainly above my level of expertise in hows of that happens, we're able to develop reports and run programs to best determine where we will have the most positive impact with the limited funding that we have. Some of the services, I don't know if this was mentioned, that, or the different divisions that we're hoping to integrate into this data system would be the human services, so drug and alcohol, mental health, children and youth, aging potentially, health choices. But in addition to that, it would also include, and I'm probably going to forget some, juvenile probation, our criminal data from the jail, and I feel like there's one more outside of the building. So again, that would, the goal would be to improve the efficiency and service delivery to those folks. Within our drug and alcohol, mental health, and children and youth units, we certainly have a lot of crossover with probation and the jail. So again, all of us having certain access to that information in an integrated way would just help us with better service delivery. Down the road, if we were to expand, as some other counties have done, to include outside data sources, school districts, for example, that would, the things that we could then do down the road would be tremendous. So the way it works, just generally speaking, is the data is de-identified, right? So for concerns about not wanting drug and alcohol to have access to all of the very private details of a children and youth case, basically one family has, a case number. It's like going to the doctor and having a medical record number. So that data is de-identified into the data system. And certain individuals then would have access to be able to retrieve that data and run reports. So I asked IT as well, since I don't speak their language, and some of the things that we talked about were the ability to improve data quality. I'm just going to read this. Improve data quality and consistency because the data is cleansed before it is inserted into the data warehouse. So we use data warehouse and integrated data system interchangeably. Enhance business intelligence to create analytics and other things. Single source security implementation, less possibility of hacking, et cetera, et cetera. So I don't even know what some of those things mean, to be honest. The state is looking at developing, well, they are in children and youth, creating a statewide reporting system. So right now, counties can choose up to, I think, one of 6 programs for all of their data and information. So the state's looking to make one data system. And ultimately, the talk with the administration at the state level is that they hope to integrate a whole lot of different human services data as well. So the same kind of things we're talking about, children and youth, aging, Department of Health, again, to better allocate resources, to improve efficiency, service delivery, all those things. So this will certainly, it seems inevitable at some point, but this would keep us ahead of the curve in the meantime. So, questions before I keep rambling? Sorry. The purchase is not for a new system. It's really for additional server space to store the data. So it's not a system. It's simply developing space on the server for all of these different, to be able to extract information from all these, 8, 10, 12 different systems to have in one place, right? So our IRIS folks go in and one screen and they pull up what they need. But it's not a system. Integrated data system. Yeah, data warehouse. It houses all of your data in one spot. Yeah.
So, I guess my question is, with so many different people accessing it, how is that HIPAA compliant?
Well, as I said, the data would be de-identified, so people would have we'll call it a medical record number. That's not what they call it. That families are only identified by that name. So the folks who. Correct, by numbers. So, like, I might be 1,562. Not, so if you went in and looked, it wouldn't be Sue Wondolowski. Plus. Oh, I get it. That's how. Okay. Plus, no, that's okay. Right. So there would be no names. There's a probabilistic and deterministic matching that they use to figure out with this name and this date of birth and this social security number what's the likelihood that it's the same Sue Wondolowski as over here? And, yeah, right. But then so then if we're deemed to be the same Sue Wondolowski, then we're assigned one number. So when somebody goes, like when Iris goes in, it would be by number. But so there will be a limited number of people who have access to the full names, but it would still not be, it's not a data free-for-all, which would just not be acceptable.
I can explain. So I've been,
not my thing,
that's right, I've been working on this with Bob, because the cost of the servers, as Mr. Cusick pointed out yesterday, is a little bit expensive. However, we're going to be running information in the background. So, for example, Tara Zarinsky goes in to sit at a workstation. You are, say, working in Iris, for example, and you're taking that call that comes into the 800 number hotline, okay? You have access to a certain level of data. So you type in a name, date of birth, that information comes together, and the level of access you have will be run through this data center and will give you information to be able to help that particular client. Now, if a children and youth worker has access, they might have access to additional drug and alcohol information for a family. It's going to be based on need to know, and there'll be security layers built in. What we need is the data warehouse to be able to have all the data in one place so then we can extrapolate that. If we integrate with the state system, we would be taking our data, supplementing what the state gives us, and then we would be able to have better information on those folks. For folks that might be in Lehigh County, might be in Northampton County, what we are doing is we are starting to integrate all of our information so that we are ready when the state says, okay, we're going to flip the switch, this is what we're going to do. And there's work that Penn State is doing in the background with algorithms and stuff like that. So the hope is, and I don't know, it's sort of like with all the data in the data warehouse, a children and youth worker gets a referral, an investigator's ready to go out, they get a risk score. That investigator will see there's a high risk. It also might be able to identify services. So the investigator goes out and can link the person up with services right away. So there's a whole lot of layers that are going to go into this that Penn State, Allegheny County is working on this as well. So this is a very, it's going to be a statewide project, and we are looking to pull all our data into one place so we're not scrambling later, and then having the upfront cost in an emergency to be able to have to store all this data somewhere. Does that make sense?
Yeah, it's kind of overwhelming when you explain all the data that.
It is. Yeah, there's phases, so there's all kinds of things that could be done in the future, but to start, the important thing is to have all of our data in one spot that's easily accessible and allows us to efficiently serve our folks.
So who's actually in charge of implementing this?
Well, IT for the large majority. I mean, I have been working with IT just in conversations and discussions and some discussions about which systems are being used and how to pull that data. But it's really an IT project.
Just a couple questions.
Sure.
First of all, is this something that's going to be competitively bid, or are we just going to work through our own IT department? Will this be a supplement?
The cost that's in there is going to come through our own IT department. We have a data room down right below our feet here that has sufficient enough space to be able to hold that. What we are actually purchasing is the additional servers. So we have the regular refresh program, so we buy them quite regularly. They are always looking for the best price. They're out on the public market space looking for that equipment. So this is just going to be additional money in addition to what we already pay for servers. Okay. So and we already own Microsoft CRM, which is a lot of the programming that will go into making the servers function. Okay. And that will all be done in-house.
Now, what do other third-class counties do?
In terms of an integrated data system?
Yeah.
So Dauphin County and Dauphin County already has an integrated data system. Allegheny County does, as Steve referenced. Allegheny County's had a data warehouse since 1999. They were like so far ahead of the curve, it's insane. So Dauphin County has an integrated data system now as well. As I said, they pay a very large amount of money on a yearly basis to maintain that, which we would not be doing. And Bucks County is about the same spot in the process, maybe a step ahead of us as well to do the same thing. So I haven't surveyed other counties to find out. I've networked with those few.
Yeah, and I think you kind of answered my next question. That was, will there be a yearly cost
Right.
for, maintaining the server and switches?
Not as, I don't know the IT answer to that.
So the servers are relatively new. They will fit into the refresh program. So my guess is you may see, yes, an uptick in the server refresh costs over the years. But the other part, if we get too much server space, if we don't need as much, those servers that we purchase or we slow down our purchasing, we would be able to, we are able to add on to this system as more integration comes online. So say, for example, we bring the drug and alcohol stuff in first, then we get the children and youth data to match up. That didn't take as much space as we needed, so now we can add the criminal. We don't have to buy anymore. So right now, based on the IT professionals that we use, this is what we need up front to get this started. And then the legacy costs aren't going to be that big because it is literally just within our refresh. And the servers are lasting longer and longer.
So is there any state money for this, or?
Not necessarily. One of the avenues that we had explored a little bit was our needs-based budget in children and youth, because they have some IT grant money. And at the initial go-around, there is not, but that doesn't mean that we won't see that down the pipe.
Okay, thank you.
Sure.
So we're getting the space. Tell me more, or do you know more about what the state itself is developing in terms of a program, or who within the state human services level is trying to?
Well, so the
create?
human services, so there was a resolution or something on Governor Wolf's desk in the last year to work on integrating all of the human services, Department of Health, at the state level. So that, to my knowledge, has not been signed, but they are in conversations about at the state cabinet level, so Secretary of Human Services, and then the Department of Aging folks that Lori referenced being here last week are having conversations about how that will look at the state level. So there's not been a company contracted with or program purchased yet.
Okay. To be continued. Go ahead.
I stepped out for a minute, so hopefully I don't ask
That's
anything
okay.
that I missed. But were you going to be able to pull reports for
Yes.
this too, like for grants, like getting grants or?
Yes. Yep, absolutely.
So it seems like, initially it's going to be a bit of a lift because you got to, get everything implemented. You have to, run
Correct.
tests and stuff till you get there. But so prior to going to this, on the backside of it, I mean, what are we doing now? Like, how cumbersome is it now?
You
you explained it initially in
That's
your
okay.
opening statement, but just.
The biggest lift is on IT. We have all these 8 systems, 6 to 8 systems in human services, plus the ones that Chris Feria from IT built for, JPO and the jail. So he has access to all of the internal systems. There's a couple of state level systems that's what we're working on. The children and youth, for example, is a state system. So and we have access to that. It's just, he's the one who is basically finding ways to take all of that data, de-identify it, and put it in a data system. So he started some work on that with children and youth already, but not, without additional server space, we can't get too much further. But there's all kinds of reports. The possibilities really are phenomenal, but and grants is just one of them. I just don't want to get too far ahead of myself.
Thank you.
Okay, is there anything else beyond? We're good with this topic? Anything
Okay.
else in your report beyond that?
That's it for today.
Okay,
Thank you.
thank you. Graysdale.
Good afternoon. Before we started, I wanted to just go over, we had invited Sodexo here to go over the food and what they do for Graysdale's residents. So I'm going to have them speak, give them the time, and then we'll come back up. So I have Kevin Blake and Judy Ryan from Sodexo to talk.
Good afternoon.
Hi.
It's an honor to be here today. Thank you very much. I'm Kevin Blake, District Manager for Sodexo. I just want to give you a little history. Not too many folks really know what Sodexo is. You probably heard of the wood company back in the day. What's that? I believe so, yeah. But what Sodexo is, they're a French-owned company, started in 1966. They've been around for about 50 years. They currently have over 460,000 employees in 72 countries and serves over 100 million customers daily. So we're backed by a pretty large organization. The nice thing for us is our office is located right here in Allentown, so we have our own regional support. In seniors, we have 613 sites in North America with about 15,000 employees. And one of the things I just want to intro Judy today is Sodexo's core mission is to improve the quality of life for all that we serve. And I'll let Judy speak in a minute because she certainly exemplifies that for the Graysdale community. Does a fantastic job. Sodexo has been serving Graysdale since March 1st, 1979. It's a 40-year relationship, and I just wanted to thank the team here because we just were awarded a competitive bid on an RFP last year for 5 years. So it was my first year supporting Judy, so I was like, whew, thank goodness we're still there after 40 years. Judy's been at Graysdale probably at least 30 of those years. She's well known there. I've been in the position for 2 years. I've been with Sodexo for 25 years. But the one thing I'll say is, and this is true from the heart, I'm new to a county home business. And out there has been this perception, oh my gosh, county home, the food, things like that. I try to really eradicate that thought because when I see the food that Judy's team is producing, homemade, scratched, cooked to order, fantastic food. I mean, it really makes a difference. And I think the residents there really appreciate it. Judy and her team do a fantastic job there, and it's very unique. Their customer service is amazing for 660 residents that anybody can call down anytime and order what they want. They select their menu. If they want this for breakfast every day, they get that for breakfast every day. I'm truly amazed at what they do. So with that, talk about your program.
Thank you, Kevin. How very nice of you to say. Okay, I have packets. I'm going to give you one, Mr.
I'll hand them out for you.
Oh, okay. I have one just for you. And
I just wanted to pull it down for you.
Oh, I'm loud. I probably don't need this microphone. I'll blow you out of the room. Kevin is right. I've been at Graysdale since 1990. I started with the wood company in 1978. I am a registered dietitian. I do think we do something special at Graysdale. And what really drives me is making the quality of life better for the institutionalized. People being in an institution, you have so much taken away from you that it really is vastly important to me to make their lives better in any way we can. And food is one of the big things for people because they have so much taken away. Food is one of the things that they really dwell on. We try to give them things that they will eat. You can serve people things that you think are good for them, but if they don't eat it, it serves no purpose. I listen to my residents. I listen to their families. I listen to the staff. We do things, I think we have probably the finest program and I'll go over, I'll tell you what all that is. But I think we have one of the finest programs in any skilled nursing facility anywhere, especially in a facility our size. We have an 8-week cycle menu. I write the menu myself. I change it a little bit every week. So we do not use a standardized menus. Most people use standardized menus. They have 5-week cycles at the most. And they maybe have a summer and a winter, and that's it. We change our menu constantly. I had a gal come up to the office and asked to see me and said, you know, can't you have fried green tomatoes? And I said, would you like that? Oh, yes. Some women on my floor and I would just love those. I put them on the menu. I made sure we could get them. We made them, talked to the chef about it, and we made them. She was as thrilled as could be. Another fellow said at the resident council meeting, I'd like a sausage and turnip stew. Well, now that's not something I would want. But, you know, he wanted it, so we got on the internet, got a recipe. He told us how to make it. We got a recipe, sounded good. I put it on the menu. I went up to him and said, how did you like that? He said, oh, I picked the spaghetti because that's my favorite. Okay, well, I put it on a different day. But that's the kind of thing we can do there. If you want, somebody said, we want more Oriental foods. Okay, so I put pork lo mein on as an alternate. I put orange Oriental pork on as an alternate. Isn't it nice that we can give people what they want, give them choices, change them around? I mean, that's what it's all about. It's all about, you know, making them happy, making their day. So anyway, we have the 8-week cycle menu. We also have something that most other people, you'll see on the menu, what the residents get. The big fold-out menu is what the residents get. They get one that size. We have 330 people who request a menu and that they can select from. We also have, if you see, a write-in list. So not only do we have a menu that's an 8-week cycle, we have a write-in list that they can pick from. And we have people, as Kevin said, we have people for breakfast. Oh, they want a ham and cheese omelet, or they want a mushroom omelet, or they want over easy. We have a lot of people who want over easy or fried eggs. No problem. Poached eggs, no problem. We don't pancakes and waffles and French toast. We make all from scratch. We have our own waffle makers. We actually make the best waffles. I used to get a waffle mix, and you know, I thought they were okay. We made that. We make our own batter now. Best waffles, I'm telling you that I think anywhere, and they love them. But we don't have those. Those aren't you can get anytime. It's basically the eggs. You can get bagels anytime with cream cheese. You can get English muffins anytime. You know, what a way to start your day. I mean, isn't it nice that you folks can get up and get what you want? Isn't it nice that they can get up and wake up to something they like too? We used to have only one hot cereal on a day. Now we have oatmeal. We make oatmeal from scratch. If oatmeal's the cereal on, that's our cereal, hot cereal. We have always cold cereals. We have all kinds of cold cereals. And they know they can get that. Matter of fact, when I went out, we stocked Captain Crunch now. You think, Captain Crunch, oh gosh. We have people who want Captain Crunch. So we get it for them. We have shredded mini wheats. People love, you know, some woman said to me, oh, I couldn't even get this in the hospital. You know, why not? Shredded wheat's the best cereal for you. So anyway, getting back to the oatmeal, we now have homemade oatmeal, whether we have cream of wheat on or farina or cream of rice. We always have oatmeal because we have so many people who like oatmeal. So that's what we try to start off people's day well. We try to make it go through so that they eat as much as they can. We have 3 to 4 alternates per meal. Nowhere else does that. One other state requires one alternate. One alternate's probably what you're getting. And we have 3 to 4, plus all the write-ins. And we do get lots of write-ins. And that's okay. Is it a challenge? It's a challenge. Has it really been a challenge for my staff? Yes, and they've been wonderful. You know, you have to keep reminding them, what if it were your family member in? What if your family member was in here? Or your child? Whatever, and they understand that. And we all have to think of that. What if it were us or our family member? And we have had lots of compliments. Families who are unhappy, I try to visit with, or the dietitians visit with, to hear them out, listen to them. You know, a lot of them feel guilty for their loved one being in the home. And so they just want to listen, or they want somebody to listen to them. So we do that. Told you we changed the menus weekly. I did include rehab. We have a daily selective menu. I did include one in there that the rehab, the unit, because most rehabs do this, they have a daily selective, and we do those. I included we have every month, and this is just an example of one. We do this on cardstock, not this kind of paper, but we do a chef stage center where the chef cooks a meal in front of 16 residents. They listen to him, they watch him cook it, and then they eat the meal. And that's very popular. We have resident luncheons. And I think there's a copy of one of our resident luncheons. We divide the house into 3. And so each person gets to come twice a year to a resident luncheon, no matter whether on their pureed, regular, ground meat, whatever. They get to come to one of these luncheons. We do theme dinners where we do the decorating. Dietary does the decorating, and that's my management staff. Our most recent one was Oktoberfest, and I think the menu is in here for Oktoberfest. Therapeutic Recreations gets somebody to come play music. Entertainer, thank you, came into my mind. We did Oktoberfest, Luau, Hoedown, Putting on the Ritz, Winter Wonderland, Cinco de Mayo, Halloween happenings, Italian night, St. Patrick's Day special. We decorate, we have entertainment, and we have a meal that goes along with it. So those happen twice a year, once in March and once in October. We also had this past year for the first time, it's actually the first time I've done one in my entire career, is we did a Clambake. That was a lot of fun. And I'm going to tell you what, the residents loved it. Oh my gosh, it makes you feel so good to walk around and see their smiles. I mean, it really does. So that was really a positive thing. You know, I have to tell you that this just popped into my head, but I can think of people over the years that have touched my heart. I can think of one who is no longer with us, who wanted us to make grape pie, homemade grape pie. And I thought, oh my gosh, you know, that's going to be a challenge. We did. We made homemade grape pie for the entire house. And I'm going to tell you what, that man, you'd think I'd have given him $1 million. It makes you feel so good to be able to do that. Somebody else, he also is no longer with us, was one of our specials, and he had wanted blueberry cheesecake. I had blueberry cheesecake as one of the desserts. He had this smile from ear to ear, and he said to me, "This is the bestest dessert I ever had." And you know, he died about a month later, and you know, I'll never forget that either. It's really special to be able to make this difference. Okay, so Family Fest. I don't want to hold too long on these things. Family Fest. I came up with that idea many years ago because we weren't using the grounds down below. That has become an annual function, and you know, I'm sure some of you have been there. I know you have, where we cart food down and families come and residents come and they really enjoy that. We have holiday meals. We have on the menu, there's holiday meals for the holidays as well as like Halloween and Valentine's Day and St. Patrick's Day. We also serve families. There's a charge for the family members, or guests, I should say, for 4 meals per year with Thanksgiving, Christmas, Easter, and Mother's Day. I'm sorry, Father's Day, we don't do it because we don't have many people sign up. But we still have a special meal for Father's Day. We just don't do a special in the dining room. So we have that, and that's very positive. You'll see I included also cafeteria menus. We do things for the staff. We offer staff. Thank you to the county who added the capability of credit cards. That's really increased our business, as we all would think it would. And we do have a very good business in the cafeteria. I've had many compliments from staff as well as visitors. We also do, we do there's an employee of the month at Graysdale, and we do an appreciation luncheon for them. We also do a Christmas meal that's courtesy of the retention committee. we used to do that years ago, and then they stopped it for a while. But I'm going to tell you, that's a real shot in the arm for the residents, and I included the menu for that in there too. I have Congregate Feeding. We do the Congregate Feeding that is now at 9 sites. I wasn't aware that they were closing the Bath site, but
We'll talk to you about that.
okay. But anyway, we do, and that menu changes monthly as well. And we do listen to them. If they call up and say, we want this menu, we put it on for them. Purchasing, I want to talk to you about purchasing, because you get something that is the best of all worlds. And I mean the best of all worlds. And that is, this is specified in your RFP, but we compare prices. We use Sodexo pricing, so you get the best of Sodexo pricing. We use US Foods Premier pricing, which is fabulous pricing, which was brought up by Kathy Anderson some years ago. And then we use a third vendor, Feasers. We compare all those prices, and you get the best pricing of everybody. So our food cost, even with the menus we serve, and I guarantee it's better than anybody else's as far as what we serve and then the quality of what we serve, but you have a better price than other people who don't serve a menu this good. And I can say that for sure. Kevin has confirmed that, and my boss, Ted, also confirmed that. So I think we do a really good job with that. We have an opening, our management staff is not overstaffed. We have an opening manager, a closing manager, and a swing manager. No supervisors, which is unheard of, and we manage the building. So I think you really do have a good deal with what you have with Sodexo. We do have EcoSure, who is a company who comes in and does food and physical safety audits every year. A passing score, you have to be above 90 or you fail. We have always passed, we've always done well. But they're there for 5 hours at least, going over everything, going over all your documents, going over, pouring through your coolers and everywhere, going into my ice machine with a flashlight. I mean, they go over everything. So that is Sodexo. That's a Sodexo program. Recalls, if there are recalls, we get instant notification that, you hear about recalls all the time. We get instant notification. We get calls from the company that sold it to us, and we're told what to do with it. So that's that's above as far as safety. Our staffing's the biggest problem. Staffing's the biggest problem for everybody these days. I do write a weekly schedule, and that's more tedious, but at least we try to accommodate we use a lot of high school and college kids. We try to accommodate them, because if I did a monthly schedule, I would have a much bigger headaches anyway. But we try to work with them so we can keep these staff. So I think we work well with that. My dietitians wanted me to tell you that they are working on the new patient-driven payment model that has Medicare went into effect in October. I'm sure you know more about it than I do, but they're working on that, and Sodexo has some new forms to help them with that, and that is to help get malnutrition reimbursed. And that's it in a nutshell. Do you have any questions?
Go ahead.
I have to, first of all, you made me hungry. I'm sitting here dying. Blueberry cheesecake hit the wrong one. Secondly, I know you personally, Judy. I know the things you do. You're gracious, enthusiastic, you're dedicated, and I didn't see any passion in your voice whatsoever. But I will tell you, my mother-in-law was in the short-term rehab for a while.
Was she?
And she's out now, she's fine. But she fell in love with the muffins.
Oh, they're good.
So you can't please this woman, okay? But she liked your muffins, so we would go get the muffins for her up there and make her happy. That's just so you know. If you can't please your mother-in-law, the muffins work. But I wanted to give
Thank you. I'm going to tell you, those muffins, if you ever get to Graysdale and you like muffins, they're the best. I mean, they're the best. We get batter from Bacon Joy, and bake them off. I'm going to tell you what, they're the best muffins I've ever eaten. And I've tried a lot of different muffins.
I think you need to bring some.
Yes.
And
I should have.
decide.
I'm going to tell you what, truly, they are the best muffins anywhere. Thank you.
Judy, you've done a wonderful job. Thank you, and for your help with all the other things, what you do with the Friends of Graysdale and stuff.
Thank you.
Thank you very much. Thank you for your
No other questions?
enthusiasm and your care for.
Thanks. You're quite welcome.
Even she had me at fried green tomatoes. Like, I was excited.
Thanks.
Thank you. Right.
From my topic.
So before we got into the report, I did want to go over the star rating. So we did, and we're at a 3-star, but unfortunately, our quality measures have gone down. So we did lose a star, so we are back to 2. The star rating is something I can equate to as a credit score. It goes up and down depending on what you have, when their look-back period is, and what they're comparing it to. So we did lose the star in quality measures. And again, it depends on who we bring into Graysdale. And my mantra has always been, when I was the director of admissions, is that I'm going to look at everybody, and everybody should be able to come to Graysdale. So we have a choice to look at, you know, not taking people and having empty beds, or we're going to give everybody a shot and fill the beds. We're 96.8% occupied at this point. But so it's a race of what you want to see. Do you want stars, or do you want residents that are well taken care of? So I did bring in Dr. Hollamser, who's our medical director, who will also address some of the star ratings and what we're doing and how we're going to improve them. So I figure we can talk about that for a little bit, and then we can go over the report a little later. So do you two want to come up?
Hi, my name is Clinton Hollamser. I'm the medical director at Graysdale. I've been in the role since January of 2016 and have worked on and off at Graysdale as a physician there, taking care of the residents since 2003. So I've been there and been very connected with Graysdale for quite a while. And it's definitely a privilege to have the opportunity to serve the residents of Graysdale, and I really enjoy doing that. And I welcome the opportunity today to answer any of the questions that you may have regarding the quality of care that we provide the residents of Graysdale, and what we're doing to make sure that's as excellent as possible.
Welcome, Doctor.
Thank you.
The star ratings, and you may have to jump in. I mean, all right, we're at 2 stars, and we want to obviously go up. But my concern is less, honestly, with the stars as much as what the stars are about. And you'll get into that. I mean, and I'll be directing this to you, Doctor. But I mean, we've had stars. We get issues, for example, if a mop was in a stairwell. I mean, over the years, they come in and they find like a piece of paper. That is less concerning to me than if it's related to patient care, because even if we take in, and I agree with what you're saying, I think that's one of the reasons we've decided to keep the home. I mean, if we were going to do what all the privates do, we probably wouldn't. But I mean, we are taking cases that are difficult. We are taking multiple, issue clients. Are any of these, I mean, hopefully we're not compromising any care for the residents. I mean, the stars, I don't know what they're for, but I would hope that none of it is, or we're doing everything to ensure that we are doing top-notch as far as medical care and that type of care, if you'd like to respond.
Yeah, I believe we are. One of the challenges of the star ratings is they're not basing those scores on an absolute level of performance that's being measured, but they're, CMS collects the data from all nursing facilities across the country and simply ranks us against each other. That's basically how the star report is derived, depending on what, quintile you fall into, you'll get 1, 2, 3, 4, or 5 stars. So looking, for example, at one of our quality metrics that we traditionally and continue to rank lower than national average, the use of percentage of residents who receive an antipsychotic medication, for example. Our rates of antipsychotic usage for our residents has steadily declined over the past 4 years that I've been in the medical director role. I believe it's dropped from a high 28% or so down to last month. We were at our lowest rate ever of 18%, of residents receiving an antipsychotic medication during the quarter. So based on our own past performance, we're making steady improvement, which I'm very pleased to see. Unfortunately, compared to other facilities across the country, we still continue to use more antipsychotics than they do. So the star rating has not improved, even though we've done better on an individual level. As far as antipsychotic use, certainly I think our patient population drives a higher use there. We definitely take a large number of individuals with chronic mental illness, in addition to the general geriatric population. That certainly, I think, rightfully raises the percentage of people who receive those medications. I am optimistic that we will continue to do better and continue to lower those rates. I was very happy that the county and the council approved the purchase of the electronic medical record of point-click care this year, and I'm starting to see what that can do for us. I've had the opportunity to serve in a leadership position as we implemented electronic medical records and some of the other healthcare organizations that I've worked at. And in general, there's 3 phases of adoption of an electronic medical record. Phase 1 we call implementation, and that's typically a struggle, for the organization, having to learn a new system, having to change your workflow processes. During that implementation phase, you're learning the basics, the things that you need to do on a day-to-day basis. Often your efficiency at work is lower during that phase. And sometimes perhaps the quality of what you're doing might suffer a little bit, as you're devoting a significant amount of your time each day to learning the new system. Thankfully, I think we're progressing now, from the implementation phase to phase 2, which we call the optimization phase. That's when you've mastered the basics of the system, and now you can start to embrace, some of the added things it can do for you to actually improve your efficiency at work and improve the quality of care you're delivering. As an example, using the new system, I was able to, in a very reasonable amount of time, do a review of all the residents that were transferred from Graysdale to the hospital, either for an emergency department evaluation or hospitalization, for the past 2 weeks. Using the computer system, I could sit at one desk, one computer terminal, and review all those, charts, reading the nurses' notes that were in there. Previously, that would have required, walking to 16 different nursing stations and pulling, physical charts and flipping through paper pages, which extremely time-consuming. But with a new electronic medical record, doing those, case reviews to identify opportunities where maybe care could have been improved, with the goal of reducing, future hospitalizations wherever possible. So that's one example of the way the electronic medical record is helping. Regarding the antipsychotic usage measure, I was able to run a report to identify all the residents, short stay residents, who were receiving an antipsychotic. Very quickly identify that, and that'll allow me or the rest of the team, to focus, on those residents and make sure that we are, continually monitoring to see whether those medications are still necessary, or whether they can be safely discontinued.
Can I interrupt
yes.
you just to get a clarification? So is it an absolute zero tolerance for these antipsychotics? Or when they come in and they do a review and then they decide to give a star, do they look at the case? Do they get a case presentation? Do they ask questions? Or they just see Ativan and go, check, and that's it?
This is data that's reported electronically, so a computer somewhere is just acknowledging that there's a checkbox that says, yes, we used Ativan, or yes, we used Haldol.
But, so how is, sorry? What was
I agree with you.
I mean, even Joint Commission at least will let you present the case. And then if there's a clear clinical rationale, then they might say, okay, well, it was used short term, it was used in a prudent and effective manner. But you're saying, no, it's absolute zero tolerance, and that's it?
It's called an MDS, and the RNACs are the one that put in all this data that they collect off the units, and that gets submitted to Medicare, CMS, and that's where they extrapolate all the data from.
So what if someone is psychotic and needs the antipsychotic medication, and that's what's keeping them functioning safely in our facility? Too bad, so sad?
Nobody, I just want to interrupt. Nobody will ever be at zero. I mean, they compare us to the state and to the nation. So no one will ever be at zero. So they're comparing, is your facility, just open them up. Pretty much that's what they're looking for. And they're doing it after admission. So once they get to our facility, they're looking to see, are you constantly increasing?
But if someone comes in, like you said, short-term stay, somebody comes into rehab, they're on medicine, you're working on decreasing that or getting them off that. Again, does that count or no? Too bad.
That's one measure. The other measure is the percentage of residents who newly received antipsychotic medications. So that's the measure that we are working on to improve as well. But again, no one is at zero. Not the state's at 1.5, and the nation is at 1.8. So no one will ever be at zero.
And where are we in comparison?
We are currently at 2.7.
Okay.
But last quarter we were zero. So, it depends on who's coming in, what they have. And, it's always on a case-by-case basis, because the quarter before that we were at 1.2. So that's the type, depending on the type of residents we get in.
And they look at 20 MDSs, so they could take 20 out of a
random
time period.
Right.
So it's random. You don't know.
And then again, if you were going to be treating a client and they come in, how long does it realistically take to taper somebody down or try different medication to get them to a safe zone? Just, I know it's case by case, and I'm asking you a ridiculous question, but just to give a sense of a timeline. I come in there, I'm on like 15 different meds, you're going to try to get me to the most optimum level. How long does a process like that take generally?
When we're looking at medications that are used for, behavior, management, and treatment of mental illness, typically if we decide that somebody appears stable and we want to, reduce a dose, we'll make that dose reduction, and usually we'll, monitor in most cases, for a period of at least 14 to 30 days before we would attempt another dose reduction.
Thank you. So it's pretty hard to, you can't just do it like that. Or you compromise patient safety. Other questions?
But if somebody needs a medication for behavioral modification, they come in at it, why is it your responsibility to reduce it when that patient clearly needed it before they came? Is that just, you're reducing it just so you can get
Well, so you can see. So the state actually expects you to try to titrate it off or go for a lower dose. If it doesn't work, that's when the doctor will.
Even if they've been on it for, like, let's say 10 years, and you're expected, okay, so you're also leveraged against other facilities around the nation. So if you take in more and they take in less, then you're always going to be behind the eight ball on that.
Right. There are nursing homes who scan the records, and if there's anything that pops up on antipsychotic medication, there's any behavior issues, they don't want them. So then they sit in the hospital. Then the hospital calls Graysdale. Please, can you come out and look at them? We need them to go somewhere. Nobody's taking them.
And how many patients do you have that are at
Approximately 400 or so. Let's say 400. What's that?
Is that 2/3 of the residents or
No, no, no.
400 is?
We were at 18% of
But that's long-term.
long-term.
Right.
I mean, today, as of today, there's 18 residents in our short-stay rehabilitation unit, 2 of whom are receiving an antipsychotic medication. One is for a mental illness diagnosis. The other one is a dementia resident. I think I looked at both those cases, and I think they're being used appropriately at this point in time.
May I interject a question? Because we're all along this line. Since it's a privilege to have you here, we can ask you questions. It helps us understand better. We've been talking about medication just in general, but I mean, for example, the example was used. Let's say there was anxiety, and I know we're talking about a population. You say the healthiest elderly person. If they're in a nursing home, there's things, and let's say that it's a Xanax or whatever its generic is. Does that classify? That doesn't classify in the antipsychotic. I mean, it's a medication, but it's not. I mean, because I'm sure quite a few probably get that. I know other nursing homes.
Ativan and Xanax, right?
Yeah.
Those are considered
Is that considered antipsychotic?
No, that's classified as an anti-anxiety medication. That's also tracked, and our numbers
But you don't get dinged. I mean, you wouldn't necessarily get. And you understand the system. It's put in a different class, but does that go towards your medication rating, I guess, then?
Yes.
If they're even on that. Okay. I'm amazed because I've been in, and not at you, at just the system, and even though I've been in it forever, and I was in it forever, I'm still amazed at how they do what they do. I mean, I was around when the state hospital was shut down, and it was an altruistic reason. We have people in that don't need it, but it was really cost-driven. So, some people came out and it can be managed in the private sector, but now we have a lot of people who are homeless and in jail. And I mean, our home is directly related to a lot of folks who probably need more medications than some other places. And I know in private nursing homes I've been in, I've had a parent in and I've had relatives in, and I know they get the physician order, but they use, what is it that they use a lot for pain? But it's, why is it escaping me? It's very common in nursing homes. Morphine drips. And I mean, now would that be considered under the medication, a morphine drip, right?
No, they don't,
okay.
don't track pain medication usage. One of the measures that they track as far as quality is what percentage of our residents are reporting having moderate to severe pain at any time.
Yeah, see, to me, that's a bit of a trickery because I'm not going to mention it, but I had a relative where we had to go in and they didn't have pain. They just were feeling upset and they were prescribed a morphine drip. And I ended up talking to the doctor about it. And personally, with no star ratings that I'm allowed to give, I think sometimes that's used as just a way to keep everybody asleep and calm. But, if a lawyer wants to come after me, so be it. But that's my own opinion. I'm just saying, doctor, you know what? You got to do what you got to do out there. And if our stars go down by this one person in county government because we're taking care of those people and they need a certain medication, you got to give them the medication. And, I'm never going to complain unless somebody's being abused. And that's all I got to say on it.
Yeah, to kind of add to Ron's point, it's skewed. It's a skewed system. My own personal life, with my father-in-law got removed out of a private nursing home because of behavior. They didn't even want to try to change it. They said, find somewhere else for him, you know, and he didn't go to Graysdale, but that's where I'd imagine a lot of those people end up going. So they kept their star rating up, and we got their client. Not particularly in this case, but I can see how that would happen daily. Thank you for what you guys do. The star rating is not as important as the care of our patients as our residents, so I appreciate that.
With the peer scoring, I wasn't aware of that until tonight, but they just keep changing the bar on you, so I get it. So, enough was said in that, but they just keep changing the bar because of the peer scoring.
Yes.
So, thank you.
Can I ask, how long has this been a benchmark that they're tracking?
They do it by quarter, it's been years.
Okay.
They've been doing it for years.
So it's not like Joint Commission that they're going to look at this, but then maybe next year they're going to change it and they're going to start looking at spirituality and how you're caring your spiritual needs?
The measures, each measure, they may change, like they're just gonna be removing the pain measure for the long-term pain, but that's what they look at. They start looking at it and comparing, and if it's the same, then they pick a different measure.
Okay. All right. Go ahead.
I had heard, and I don't know if you're doing it or not, that there's alternatives to this, to the types of medicines that they're trying music, trying things that will be better than a morphine or something for people that need it. Has that been incorporated in any of the work you're doing?
Yes, it has. We did begin the National Music and Memory Program at Graysdale a few years back. I was able to get a grant from Lehigh Valley Health Network to fund the purchase of 100 iPad devices, roughly, that our therapeutic recreation staff work with the residents and their families when we've identified, people who may benefit from music therapy. So we are using that as an alternative to medications to manage, anxiety or other agitation.
Did you have another question?
You can, as a doctor, I mean, if medical marijuana is legal in Pennsylvania, and look, I know, and that touches, no, wait. I'm asking, I think it's a fair, it's a fair question in the sense that I'm not going to make a judgment call because I know when it comes to addiction and there's groups, and so I'm not saying it's good or bad, but it is now legal in the state of Pennsylvania on a medical level. And it was brought up about alternatives to standard medicine. Is that ever considered? And I'm not here I can't possibly judge whether somebody would benefit from it or not. So I would hope others would take that same stance that are not medical professionals. But I'm asking you as a medical professional, not your stance on it, but is Graysdale in a position where if it was warranted and the family and all kinds of hurdles you had to jump over, would they be allowed to get that? If you thought, are you the one that would have to make the decision, even if they wanted it?
Yeah.
Oh, well, all right, you couldn't do it. All right, thank you, Bob. Go ahead. You're more weed articulate than me.
Judy's muffins are going to be disappearing faster if we do that.
I think it's a serious
what she was going to mention.
question.
The problem for nursing facilities, I think anywhere in the country, to use the medical marijuana right now is that we all receive federal funds, and because it's still illegal on a federal level,
fair answer.
It probably prohibits us from. Yes.
Yeah, I didn't think of that. You're right. I mean, I get it. No, thank you. It was a serious question, but I understand what you're saying.
And we've way digressed off the point that you were trying to make in terms of, I guess my concern personally is, and I think Mr. McClure started this whole meeting in the same vein, is that I've always felt like as long as you're working on good standards of practice everywhere you can, then you shouldn't have to worry about star ratings because you're going to get them because you're doing good standard of care. So do you believe that the issue is not the standard of care? Or do you just think there's some areas where, again, by comparison, we're always going to have problems compared to these other facilities? Because I think we have to be honest about that.
Yeah, I mean, we're definitely at a disadvantage, with our resident population when you make comparisons. I think we're definitely, challenged that way. Can we do better? Yeah, of course, I think we can do better, and I'm looking forward to harnessing the power of the new electronic medical record to help us, as we, strive for the best, quality that we can deliver. I mean, we have, we met, within the past week and just re-examined, what protocols we have in place, looking at the specific, quality, indicators where we're, behind, state or national averages, and we do have plans that we're in place and that we're, working to improve upon.
I didn't mean to stump you.
No. I'm just pausing because I'm contemplating going a little off script here.
There's a lot that this new team we're putting together, we're starting to really do deep dives into each and every measure, and we're coming up with a plan for, like, say, the top 5, measures that we really need to look at. And that's where Dr. Hollamser comes in, because he's more than willing to say, okay, you know what, give me that report. Let me look at it and see where we can go. So this is a different approach that we're taking. We've never taken this approach before, because now we have those reports that we can pull out of that system. As Dr. Hollamser said, it's impossible for him to go to 16 different units and try to pull up who's on antipsychotics. Like, let me see why. Where's their record? Then he'd have to go up and physically pull the chart. Well, now everything's in electronic. So, I have to give him kudos because, he's really been an integral part of this new action plan that we're trying to do, break down the measures. We talk about it as a team, and then we'll regroup, maybe in a couple weeks and see where did we get, how did we do, what can we change. So I think that's an important part to know. And yes, the stars are important, but this is more important to really get to the root cause.
Yeah, long term.
Yeah.
Okay. We have about 10 minutes left of our meeting time. Is there anything else we need to review, or?
Did you need him to say and spell his name clearly?
Yeah, the first name is Clinton, Clinton. Last name is Hollamser, Hollumzer. Welcome.
Thank you for what you do, sir.
So again, we continue to work on all of our quality measures. And again, it is a living and breathing number, so next month it could be totally different. So if you look at the first page, if we want to go over this, the Graysdale census and the PPD. For September, the average daily census was 662. The target for the facility is 670. So we continue to get more people in. Cost per resident day for September was $223, with the year-to-date average being higher at $349. The Medicare rate that we've been getting is, all-inclusive rate is $434. And the hours of care per day average about 3.25 for staff.
The census bonus, are we on track to hit that number for the end of this year?
Yes.
We will reach that.
My admissions is working very hard. We did lose a couple of residents over the weekend, but we have a wait list for mail.
Well, what is our average that we have to hit in order to reach
We
that?
aim for 660. That is our goal.
660 will get us that additional bonus money that okay. And we're at 665.
662.
Okay.
Averaging for September.
Okay. But for the year, we're at 655.
Right.
So All right, so we need 5 more to make the bonus payment. All right,
Yep,
thanks.
they're working very diligently. So the next page goes over Graysdale's finances. August revenues are 4.9 million. We were down 100,000 from July. And in 2019, monthly average revenues are about 5 million. Expenses are down in 2019 to 4.4 million as compared to the 5.4 million in 2018. Year-to-date expenses are $800,000 more in 2019 compared to 2018. Capital spending, again, we got the new paging system. It is up and operational, which was a godsend. Paging through the phones is great, but when you really need to find somebody, a resident wandered off the unit, the overhead paging system is still the best. Graysdale's admissions and discharges, the total admissions were 28. There were 126 inquiries. Of some, like I said, in September, we had a block with male beds. We couldn't go anywhere. We had a lot of people waiting to get in, which was a good thing to have. Staffing and callouts. In the month of September, we hired 16 new employees and terminated 3. The year-to-date trend is obviously a good one. It's positive for hiring new employees. So the IFML rate callout rate was September was 28%, so it was down from the 33% in August. Staffing, while the RN and CNA vacancies are up this month compared to August, they are down in the LPN categories. So we hired some LPNs during September.
Excuse me.
Yes.
Can I, the 28%, is that of the folks that were out, right? Not of the total population?
Right.
Just of the folks that were out?
Correct. So if you look at the, down to the right, the call-outs year-to-date, you have 4,600 call-outs, 4,602, or 27%, or so 1,251 have been related to the IFMLAs. Goes over workers' compensation claims. In September, we had 4 claims, the same as August. The number of lost days were slightly less at 120. Safety first, we can constantly look to improve safety. We're working with the Human Resources Department. We have a gentleman coming in January to help us with our safety committee meetings. And he's going to go over and look at Graysdale as a whole and maybe see if we have any weaknesses. Modified duty, there are 2 claims in September, down from the 4 in August. So the total number of days was 60, down 45 days from the month prior. Wounds, infections, and treatments. Wound care, in month-end wound care, the wound count was 51. It was down 15 wounds over last month in September. We treated 82 residents compared to August 95. Healed wounds, there were 21 wounds healed at Graysdale this month. 10 wounds are no longer being tracked due to discharge or resident expired. Infections at Graysdale, the total number of infections were lower in August at 79 compared to 85 in August. Urinary tract infections and sepsis showed an increase in September compared to August.
For infections, is that compared to August of last year or?
The previous month.
Okay, but it says in August compared to 85 in August.
Oh.
It should
It's
say
just September.
So in September, it's 79 compared.
Right, compared to
okay.
85 in August.
Scribner's error.
New initiatives, again, with the point-click care, like the doctor had stated, we're doing new things. We're implementing more pieces of the point-click care puzzle. So we have the wound going live soon, and that's going to be able to help us with fixing our wound issues. Incident and falls. We had 195 falls in September involving 111 residents. Injuries of unknown origin were 58.
That's an interesting category.
Overall incidents are up 40 to 339. This number is slightly below the 343 year-to-date monthly average for Graysdale, so we still are trending down. Training is the key. Our staff development team does a great job in getting out to the units, as well as Medline, which comes in, helps train our staff. Resident safety, we're always striving to maintain and improve resident safety, so we can increase Graysdale's ratings. On the dementia unit, right now, what I had put in place was a quiet area. So we have 2 recliners with some walls around it, and then we have a bubble machine that we can regulate how fast the bubbles go, so we can slow them down. And if somebody's acting up with dementia, we can put them in that area. They can watch the colors in the bubbles, and it's soothing. So it's one of the things that we're doing to kind of remember that safety's first. It calms them down.
I was going to say.
I was going to say, I wish. I should install one.
Stressful days, bro. For sure. Kevin.
And then,
Good one for you, Kev.
so the quality measures that you see on the back are for September. The ones that we were discussing will be the ones that we'll be discussing next month, because they'll be for October, where we had the shortfalls. And again, we continue to strive. There are some things, one of the, where we went down was people discharged to home, and unfortunately, when they were discharged to home, they went out to the hospital within 30 days of discharging out of Graysdale, and that counts against us.
Really? Mm-hmm. Sorry, it was out
Our
loud.
social service department call them after they discharge, and they follow up week to week, but.
You know, I hate to say that, I have a whole new appreciation for all of this, because I could see why that happens. Because things happen quickly in that population that you don't expect, and.
And they want to go home.
Yeah, yeah.
And the short-term rehab unit, when we designed it, we knew it was always going to be a feeder program. So if we have short-termers and they don't go home and they convert to long-term, well, they look at that as well.
Chair,
Go ahead.
I just want to make a comment.
Sure.
This is great. I don't know who came up with this format, but it's like being in high school, you know, and you're trying to get the kids like to understand. I mean, it's enough information that it's easy to digest, and there's enough there that if you have a more in-depth question, you can feed off of it. So whoever came up with this, kudos. I think it's great. It's easier than following the lines.
That's
the
right.
type is big for people with
And the
Ocular
colors are
challenges.
flashy for you.
yeah, ocular challenged, age challenged, all kinds of challenged. But anyway, I just want to compliment whoever did this.
Mr. Heckman, most importantly, the information in these is accurate compared to the Premier reports that we all discovered were not accurate after Premier was gone.
It's nice.
Anything else?
Anything else from anyone, since I'm at the hour? No? You got a face. You okay?
He almost has a face.
Okay.
Spreadsheet was fine with me.
He's a math guy. He liked the spreadsheet.
Give him squares, and the rest of us will keep the colors. Take his colors out, give him black and white. There you go.
Just the numbers were fine with me.
What is that, right brain, left brain, John? He's right brain challenged?
Well, we'll see you again, I'm sure. With that, can I adjourn the meeting?
Good
Thank
night.
you. Could we take a minute before you want a minute? Oh.
Thank you so much.
Thanks, Doc. Thank you very much.
Appreciate it. Wow.
Have we ever had a medical director? Have we ever had a medical director?